Hello everyone. My name is Joseph Hewett, as I'm sure many of you know. You'll see this name Synergy Health up here. The larger portion of our medical practice is called Pacific Interventionists, but we decided to create a focused portion of our practice called Synergy Health, concepts to deal specifically with CCSVI. I'd like to thank all of you for welcoming me back to Alberta. It's actually been a while since I've been back here. I was just thinking this morning, one of my most memorable trips out to Alberta as a kid, I spent 12 hours sleeping in a luggage rack of a Greyhound bus as my scout troop moved from Manitoba out here for a scout jamboree. Michelle promises me that I won't have to spend any time on a luggage rack as I go back east. On a more serious note, not only would I like to thank you, I'd like to congratulate all of you, every single one of you. I'd like to congratulate you for your spirit and your perseverance. I know that it's not easy fighting for something that you believe in, especially when there's people from many walks of life who are telling you that you're wrong, or that you should just shut up. That can be a difficult thing. And not only would I congratulate you, I'd like to tell you to keep pressing forward. I think it's really important. In my opinion, you're not fighting for a surgery, you're not fighting for a procedure, you're fighting for an idea. And that idea is that the people in my profession, in the profession of medicine in particular, should be willing to consider a new way of looking at neurodegenerative diseases such as multiple sclerosis. I don't think you're asking us to abandon any of the treatments or any of the methodologies or the knowledge that we've acquired, but I think you are asking us to think about, investigate, and treat neurodegenerative disorders in a new way, adding to or supplementing what we already know. I think it's not too much to ask us as physicians in the medical profession to consider the possibility that neurodegenerative disorders like MS may have at least in part, a neurovascular and potentially and more importantly perhaps, a neurovenous component to their etiology. Okay? So, having said all that, I'm sure I've stirred up some trouble somewhere. And I'm going to try and stir up a little bit more trouble here. I'd like to talk to you about venous stenting. There's a lot of information out there about stents and whether it's appropriate and what stents are for, and arterial and venous stents. And I'd like to shed a little bit of light on what I believe, maybe some of the truths behind stenting. I'm not here talking to you today because I think all of you should rush out and ask a stent. I think stenting should be a last resort in any treatment of any vessel, whether it's an artery or a vein, but I think it's important to be educated. And if you're going to approach any subject, you should understand it fully. So let's try and understand stents a little bit better today, okay? First of all, I'd like to talk to you about the history of vascular stents. I'd like to talk to you about some of the uses of stenting in the venous system, some of the uses that we may consider in CCSVI, some of the potential issues using stents in CCSVI, and then just some summary topics. Way back in 1856, there was a dentist named Charles Stent who had a metallic molding compound, and this is how we get the word stent. That's Charles on the right side there. The first documented human cardiac catheterization, which is really the precursor to all of this, was performed by a doctor named Werner Forstmann in Germany. A very important man in the world of interventional radiology is Dr. Charles Dotter. He started and actually invented the process of transluminal angioplasty. About a decade later, this was improved upon by Dr. Andreas Grunzig, who first performed this procedure in a human being. Jump forward in 1994, and you have a pivotal moment when one of the first stents, the Palmaz Schatz stent, was approved by the FDA in the United States for use in human beings. Now, interestingly, this stent was approved not in arteries, not in veins, it was approved to be used in the liver. which is where we get the foundation for a lot of our stents. In the subsequent years, the use of stents took off, and most recently, in 2003, the FDA approved the use of drug-eluting stents. There's been a lot of talk about arterial and venous stents, stents being designed for the arterial or the venous system. As I mentioned, the first stents were actually designed for use in the liver. Well, since that time, we've taken these stents and we've used millions of them in arteries and veins. And most of the stents, many of the stents that have come subsequent to that initial design are really based on the same principles. And many of them were approved to be used in the liver, and were subsequently used in the arterial system and for decades in the venous system. I think it's somewhat disingenuous if someone were to say to you that you shouldn't use stents in the veins because they were designed for the arteries. Go ahead, Michelle. The role of stenting in the central venous system, and we consider the jugular veins and the azygos vein and other veins in your chest the central venous system, it's been widely adopted. It's been so well adopted that, in fact, the large medical societies that govern people like myself, one of them is the Society of Interventional Radiology, have long established guidelines for placing stents in the central venous system. Now, having said that, I think it's important that we all remain skeptical of everything that we hear. I want you to know that there is no conclusive patency benefit that has been established for stents over angioplasty alone. Here's a really good example. This is one of the first cases of stent use in the central venous system. At the bottom of your screen, you see those white lines. Those are the iliac veins. In the background is the spine. You see the iliac veins coming up on both sides, and they would normally form a single vein that goes back to the heart. This is a 55-year-old man who had a process called retroperitoneal fibrosis, which is a really insidious disease. It's a fibrous reaction along the back which goes out and grabs the blood vessels and just closes them off. So it closed off his IVC, which is a big blood vessel that leads from the pelvis to the heart. IVC is inferior vena cava. This was back in 1990. So what's that, 21 years ago? That's okay. This is a fellow who, he had this obstruction. It was angioplasty, it was eventually stented, and the pictures that were on the right side are the pictures that he wouldn't have flow without those stents. So when people are saying to you, stents shouldn't be used in veins, stents have been used in veins for a very long time. May-Thurner syndrome. I'm sure a few of you have heard about this. There's a diagram, a cartoon on your left, and essentially what May-Thurner syndrome is a compression of the blood vessel that goes down your left leg by the artery that goes to your right leg. The one blood vessel lies on top of the other, and in certain people, it'll cause obstruction of flow. On your right side, it's a little difficult to see. There's some black arrows that point to the blood vessels trying to bring blood back up, but they can't because it's obstructed. Okay, Michelle. On the left side is an angiogram. You can see that little string of contrast. This is obstruction that persists even after angioplasty of that blockage. The angioplasty wouldn't open it up. It's a very commonly used practice to put stents in that vessel to keep it open. We've been doing it for a very long time. On your right side, you can see the result after a stent has been placed. Those are the arrows, and the blood flow has returned to normal. Okay, Michelle. I'd like to diverge for just a moment here to stamp out some misinformation. We get a lot of patients who come to our practice thinking that because they have CCSVI, you have an increased incidence of May-Thurner syndrome. You have vein problems up here, so you have vein problems everywhere. That's not really the case. A wonderful study that was just shown at the recent meeting for the Society of Interventional Radiology studied 160 patients who were being treated for CCSVI and who were also evaluated for May-Thurner syndrome. They found that 17% of those patients had this problem. Well, it turns out that if you study the general population of asymptomatic people, essentially there's no difference between the incidence of May-Thurner syndrome in CCSVI patients and in everybody else. Okay? So in our practice, well, I would say in general, the practice of routinely looking at Maitland should really be questioned, since there's no difference. Uses slightly more radiation, slightly more contrast. So I would say to you that unless you have left leg swelling, unless you have a history of blood clots in your left leg, there's probably no good medical reason to look for Maitland syndrome in you. Okay? Another process that we've used venous stents in for a very long time is called SVC syndrome. On your right, just as the IVC coursed from the pelvis up to the heart to bring blood from the legs up to the heart, we have the SVC that brings blood from the arms and the head back to the heart. You can see how it's very narrow, right in the middle of that picture on the right side, and that's an obstruction due to cancer. This man had lung cancer. His picture on the left side is what his face looked like because of that cancer and that obstruction. The blood could not return to his heart properly. After treatment, his face looks on the right, like it does on the right. Go ahead, Michelle. He had an angioplasty of that area of obstruction in his SVC. The angioplasty didn't work, and a stent was required. This is a very common practice. I'm sort of in the middle of my career, and I've been doing this for about 14 years. There's many guys who've been doing it much longer than me. In our practice, we perform approximately 10,000 venous angioplasties a year. Many of them on patients who are on dialysis. Patients who are on dialysis get central venous stenoses very frequently. This is a patient, the blood vessel coming in the picture on the left, this is the subclavian vein. You can see where that arrow points, it's in the brachiocephalic vein. There's a narrowing. Angioplasty didn't work, and this patient required a stent to restore normal blood flow. Their arm was about 4 times the size of normal, and this was the only thing that would help them. And another case of a subclavian vein obstruction. Angioplasty would not open that up, and our only choice after trying to angioplasty it multiple times was to use a stent. Go ahead. Let's talk about the azygos vein. The azygos vein is a peculiar vein. Many of the systems in our body are built in twos for backup. The azygos vein doesn't have a backup really. It's a singular vein. It's shaped like a shepherd's hook. It's on the right side of your body, and it comes up into your heart and makes a hook. There is one component of it that crosses the spine that's called your hemiazygos vein. Go ahead, Michelle. This is an MRI, or more accurately an MRV. An MRV is a type of MRI. And this MRV shows the azygos vein. It's as though I were looking at you basically from the side, okay? One of the arrows down there points to the hemiazygos vein. This azygos vein actually looks pretty good. No significant narrows. Go ahead, Michelle. On your left, you'll see that there is another azygos vein that has some areas of compression. The pictures on the right side are, is there any way to dim the lights a little bit perhaps? It might make it easier for people to see. Well, I'll continue on while they think about that. You can see there's a white slit right in the middle of those pictures, and that's the azygos vein being compressed. Go ahead, Michelle. So then the question is raised, well, what do we do about it? On your left, the catheter has been put far down, thank you, into the azygos vein, and we've done an angiogram. Is that better? Okay.